bit more time to join in. So thank you for taking the time out, everyone. It's really good to see you all here. My name's Alex. I am a practice liaison officer working for the RCGP RSC, and I'll be supporting the study and be your key point of contact if you're an RSC practice. I'm just going to introduce Brendan Delaney. Brendan, do you want to?
Hi, yes, welcome. So my name is Brendan Delaney. I am a general practitioner, quarter-time partner at Albion Street Group Practice in Rotherhithe, Canada Water, in South East London, 1 day a week, and the rest of the time I'm based at St Mary's, and I'm chair in medical informatics and decision making at the Institute of Global Health Innovation at Imperial College in London, and I'm one of the two joint chief investigators of the RECAP study.
Thank you. We've also got from the team Liba.
Hi everyone, I'm Liba. I'm a part of Trish Greenall's team from the Department of Primary Care Health Sciences at Oxford. I'm also a practice liaison and I work with Alex and Anna to facilitate between the Oxford and Imperial arm.
Thank you. And then we've also got Anna.
Hi. Thank you for being here. I'm a general practitioner in Berkshire. I'm also working part-time in Imperial College as a clinical research fellow. I'm working with Brendan Delaney, but I'm also liaising with the Oxford team and working with Liva and Alex in practice equipment. So thank you for joining us.
Thank you. And then we've also kindly got a member of the team from Ardens who will be talking us through the template later.
Hi, so I'm Merlin Dunlop. I'm a GP in Oxford, and I'm also medical director for Ardens. So we've developed the template, which I'll be going through at some stage during the webinar.
Thank you. Right, just before we get started, can I just remind everybody that this session is being recorded, so you may want to turn off your webcams if that's something you don't want to consent to. And can we also advise everyone to please remain muted throughout this session, and if you have any questions along the way, just pop them in the chat to your right. So we'll move through, and just to start us off, Brendan's going to introduce the RECAP study to us. Over to you, Brendan.
Thank you. I'm only going to use one slide at one point, so rather than sort of death by PowerPoint via Zoom. I think it's important to think about what we're trying to do here with RECAP, and this goes back to March, April time, and the early part of the first wave of coronavirus, when there was a lot of concern amongst GPs. How do we reliably assess patients who are presenting with acute COVID, and how seriously ill they are likely to be? Are they likely to end up with hospital admission? Are they likely to end up in ICU? What's their risk of death? And I had a bit of a Twitter discussion with an old friend and colleague of mine, Trish Greenall in Oxford, around this very issue, particularly how do you assess breathlessness as a component of that. Some criticism on both our parts of the Roth score, which was being put around at the time as being something that could be used. Some discussion around News 2 and whether it was appropriate. And then Trish had started a project to develop a set of consensus guides to assessment of acute COVID. What are the likely things that GPs ought to take into account based on our experience with this new condition? Where clinical experience is the only thing that can currently really guide us. So she developed with a group of GPs, myself one of those, through a Delphi process, a set of data elements that we think were important and how those might be assessed. So this is the very beginning of the development stage of a risk score. The risk score being to hit that exact spot. You're a GP, you're probably remote consulting with a patient via telephone or video. You have a patient in front of you who has either a clinical diagnosis of COVID or has had a positive COVID test, and you need to know what to do with them. Are you going to just give them advice, reassurance, self-care, contact if necessary? Are you going to monitor them more closely, perhaps put them on one of the lists of being out in localities for keeping sort of amber flagged patients and contacting them every day to see how they're doing? Or are they red flagged? Do they have features that say, well, I want you to be seen in an A&E department or in the local acute hub, depending on the pathways locally? So how can we guide that with a risk score? So the next step in development of this was to translate the data elements that we thought were important into specific codes that we could put into the record. So there was a working group set up involving myself, Merlin Dunlop, and a couple of people from Northwest London, Simon Gordon in particular. And we worked through a series of meetings where we came upon an agreed set of codes that expressed the clinical concepts that we're interested in, and were codable using SNOMED terms that were available in EMIS and in System 1. The next step was to put those into templates in Northwest London and nationally that were made available through Ardens, that we can then know that they go in the record. And they go in the record with a specific SNOMED code for consent to record linkage. I think we'll talk a little bit about consent when Merlin shows the template, because it'll be easier to talk about that. The idea is to build a prospective cohort of coded data elements that we can then link with the study outcomes. And the linkage is happening in two ways. Either in Northwest London, where there is an agreed setup of data linkage across the health system called WISIC, so we get the data from the acute trusts, plus all their tests and their admissions, or through RCGP RSC practices, where there are mechanisms through the RCGP RSC network. When the data is extracted through Apollo, it can be linked with HES data and ONS data to look at hospital admissions and discharge. So we end up with a data set where we have the indicators, and I will pop those up now. Let's find this one. There we go. Okay. So that list, those elements from 1 to 8 with some A's and B's, are the elements that we're going to be collecting in RECAP. So we're going to test to build a statistical model that will, sorry, apologies, a statistical model which will take those elements and say, should these stay in the model? Do they contribute anything? If they do, what weighting should we give it? So it's a bit like Q-risk or Q-cancer, for example. So there will be an algorithm with some of these elements underlying it, which will give a percentage prediction outcome of hospital admission, ICU admission, or death, that we can put cutoffs, say that's green, below that, this band is amber, and above that score is red. And we need 2,800 patients nationally to do that. And we're obviously keen to gather that many patients as soon as possible, so we can start to use this validated score in management in patients during the second wave. Merlin, I think probably it would be a good point to dip in and get you to talk about the Ardens templates. And then when you get to the bit where the SNOMED code for consent is, then I can talk a little bit about consent, because it'll probably make more sense looking at the thing. What do you think about that?
Yeah, that's absolutely fine. I think you need to allow me to share screen.
I've just done it. Okay.
Thank you.
If anyone has questions that come up as we're going through this, please do put them up in the chat.
So hopefully everyone can see my EMIS screen. Can you see that okay, Brendan?
Yes, yeah.
This is a dummy patient, obviously. I'm going to run the template as you would run it during a consultation. So just using the run template at the top here. If you haven't used it before, you'll need to search for it from your template searcher. It's called novel coronavirus. and COVID-19, so whichever element you search for should be findable. The latest version is version 15.8. Now, I think that it's a very comprehensive template is the first thing to say, so don't be bamboozled by the size of it. The bits that we're most interested in from the purpose of RECAT are these 2 pages, remote clinical assessment and face-to-face assessment, but the whole template is available, obviously, to comprehensively cover COVID cases. So there are a number of elements in terms of assessment type, and Brendan's going to talk a bit more about the consent. Do you want to do that now, Brendan, or later on?
Later on, I think. Yeah.
So the recap study consent box is here, but we'll talk about that specifically. So the key things really are in the history and the examination part. So all of these entries here, if I just minimize this alert box, all of these entries here are coded data entry items. So you've got ethnic category at the top here, and then you've got all of these items, and the various options in the drop downs are all SNOMED codes. So the idea is that you're able to record things in as consistent but also specific a way as possible. And then similarly for the examination. Now, breathlessness in COVID, as you'll know, is slightly tricky because there's a few different elements. So we've done a little bit of a breakdown of the elements of breathlessness. So difficulty in breathing, and then level of breathlessness, sentence completion or not, and then the direction in which the patient is heading clinically. And then again, examination findings, these are all coded data entry. There are the COVID specific codes that are within EMIS and System 1, so you can record if it's a suspected case. And then down at the bottom here, you can record management plans and follow-up and the giving of safety netting advice. The face-to-face assessment is very similar. It has all the same codes. The only differences are that it has removed the peak flow as an aerosol generating procedure, and there's a couple of other minor adjustments in terms of the type of consultation at the top here. So you've got face-to-face options as opposed to telephone and video options. So I think that's probably all we need to go through at this stage, Brendan. As I said, there's many other pages, but those are the key ones for recap.
And there'll no doubt be specific questions. So let's deal with consent. We have approval from ethics to do the study as a record linkage study. And the idea behind it is that what we're making sure happens is that things that you might otherwise have written in text or perhaps coded in an ad hoc way are coded in a consistent way using the template. And these are the kind of considered best practice things that should influence or thought to influence the decision about risk rating a patient with acute COVID. So what do we need the consent for? We need the consent for record linkage, in that we plan to link this up with HES and ONS data, and we're not exposing any patient's individual data. It's just, case 1 had these features, this was the outcome, the statistical analysis. So here is a link to a web page which has a brief bit of patient information. So the way you would do this, you would say to a patient, well, because COVID is a new condition and we're trying to work out how best to predict the immediate risk of patients, I'll be asking you some clinical information. I'll be recording those on the records. We'd like to be able to link that data up with what happens to patients longer term. So we'd like to put in that you consent to have that information linked up. It's completely anonymized. No one else will have access to your personal data other than the researcher. Are you happy for that to take part? I can send you a link to a website with further information. And you could perhaps do that through an Accurix or whatever other way that practice uses in communicating with patients, if they want that further information. If they say yes, you put in the Dropbox down here, which Mandy's going to show you, consent given to participate, which is a specific code with our CPMS ID number which needs to go in there, which is presumably if you get from clicking that. Unfortunately, at the moment, this should be pre-populated, but EMIS seem to have broken the ability to do that. I'm working out with EMIS if they can fix that at the moment. But at the moment, you just need to type it in. It's from there. And that means we can then pick up the data from searches to do that. In Northwest London, we have a whole systems integrated care data set where there is already governance approval for anonymised record linkage and secure access to researchers through that. So the Northwest London GPs are not having to do that consent step. The funding for the study comes from two sources. It comes from an NIHR grant, ESRC grant, which is held by Trish Greenhalgh in Oxford, and a granted Imperial from what's called the Jameel Community Fund, which is a philanthropic fund at Imperial for COVID research. And there is payment coming for support from the Clinical Research Network to support the additional data entry and any training necessary to use this in practices. That's currently being worked out. And there is some payment available for RSC practices as usual in RSC studies, which supports the process of additional time of getting consent from patients. Okay, I think I've covered everything I needed to say. What about from the Oxford end? Are there any additional bits that we needed to add in there? Okay, so should we go to the chat? There are some questions up on there. First one, does the template take account of the patient demographic as this will affect the outcome as well as assessing the patient? The patient demographic information, so age, sex, relevant comorbidities, BMI, all the things that we know are risk factors for COVID outcomes, we will gather that information as part of the record linkage. So I think that's likely to be a significant driver of this algorithm, as it is in all the other ones that have been done. And there isn't a primary care one, but there is a one on hospital admission that can be used. And there were features in that. So I'm sure they will come out of those, and those are taken automatically from the record because they're coded already. You don't have to separately code those. The step after doing this research and getting the algorithm is to build the algorithm into the template. So you automatically get the calculation and the banding as to which risk this patient is. At the moment, all the templates in use across the country are using national recommendations on what's the care pathway for these patients, which is largely based on the news score plus some additional factors. It's the best guess for managing patients. Too complex, no guidance, what's complete? Big issue for non-GAP people to want or know how to do in real results. Okay. Well, I think this is about time, isn't it? About how to fill in a template. I think, fair to say, if you've got a patient with acute COVID, you're going to have to do a fairly careful clinical clinical work through with them. You can't just sort of say, well, I'll give you a bit of advice, likely acute COVID, doesn't seem breathless on the phone, and leave it at that. Because these are patients who could be at home a couple of hours later, become hypoxic, could collapse and die, could have quite serious outcomes. So any clinician seeing these patients is going to want to carefully document and safety net those patients. What the templates are doing is offering you a standards-based way of doing that, where you can code up quickly using drop-downs. It's actually quicker to use the drop-downs than it is to work through a set of text and things that is a comprehensive record. I think that's well recognized. So it should certainly take no longer. The consent aspect will take a little bit longer, but there will be payment for that. But it shouldn't take more than a couple of minutes. Not giving guidance, well, we can't give the guidance yet because we haven't the score to give the guidance. I think if that's what I mean by that. The drop-down text should be fairly self-explanatory from what Merlin's shown. Does it give you a risk score? Not yet. We need to do the work to create and validate the risk score. So by doing this, we will get a risk score. And there's nothing in primary care at the moment. We're completely in the dark.
Brendan,
yeah.
just to come in on the last point about, do you have to fill in the whole template? The answer is no. The template, none of the fields in here are mandatory. Now, I don't know how that's going to work with the data linkage stuff, whether you're going to have a sort of dependency as if someone hasn't filled in the following boxes, then we're not going to look at this case, or how it's going to work. But from the purpose of the person filling it in, each of these data items is standalone. So you fill in whichever ones you want, and then save the template, and that data will go to the record. It's not going to sort of alarm you because you haven't filled in a certain box or something in the template. So the idea is to give you the tools, but it's still up to you, the clinician, to decide what you're recording.
Yeah. It's verbal consent. We have agreement from the ethics committee to take verbal consent and record it, because it's a very low risk action. We're not doing anything to the patients. We're not actually collecting any information that would be over and above what would be standard practice to collect anyway. So it's almost not in the research category. What makes it research is the fact we're taking the data and doing secure record linkage with it to derive a score. One might ask the question, well, why call this research? Why have a template? Why have the CPMS code? Because otherwise, none of this data would be properly coded or recorded. If you weren't using the template, you'd end up with a data set extracted from practice, which was very, very incomplete. And with such disparate codes, you wouldn't be able to make sense of it from the point of doing it. So you may ask, well, why haven't the Q research team produced an acute COVID score? Because they don't have the codes within that. So we need to do this prospective code collection. So it's a bit like very light touch observational research embedded in clinical practice. Okay, so I'm just running down. Yes, verbal consent, need for more signposting, STAR remote clinical assessment, face-to-face assessment for CPMS, market in the template, and to complete and you fix. So it's ways about practices could try and get the template filled in without having to get the GP to do it, I think, is what you're saying there. Merlin, presumably these templates could be filled in partly and then passed on to someone else to do, because as long as the data's in there.
Yeah, I mean, I guess it comes down to the clinical judgment thing. Is the person doing it sufficiently trained to be making the judgments about the various aspects of the patient's history? There is a reception assessment page here, which is very high level, but this is just for reception to triage a patient effectively. But when it comes to clinical assessment, I mean, I guess that's up to the practice, really. Anybody can use this template. It's not locked down to role profiles on EMIS. But on the other hand, I think some of it is things that require a clinician really to make a call on, and therefore I would be slightly careful about allowing administrative staff to fill it in. It's more than that.
Yeah. You can use a template at every contact with a patient. In fact, I would encourage people to do that, and I'm kind of hoping that for patients in that medium group who are having regular contacts, these are the things that you would want to be capturing every time. So you'd be looking at change in trajectory of dyspnea, change in oxygen saturation as being important factors in determining whether that patient who's being monitored needs to be sent for admission or for a face-to-face contact. So the trajectory is going to potentially be quite important in the analysis of the data. Yeah, we're developing a risk score. You're mentioning risk score. There is no risk score at the moment. This is the collection of data elements which we're going to use to develop a risk score. And that will come up with accuracy. So a ROC curve, the relevant cut points, the area under the curve, the predictive value at different points for that patient. And the idea is, well, the plan is you get a data set and you split it 70% to create the score, and the remaining 30% to validate it to see how predictive it actually is. We are going to use both standard regression tools and do some work with machine learning and AI development on that. Part of the group are linked up with doing machine learning. So I think will be quite interesting from that point of view. Does the ethical approval specifically allow for consent to be done by staff who do not have GCP? There's no requirement of GCP. This is standard clinical practice, and we're just capturing this light touch consent for record linkage through there. It's not a full-blown clinical research thing where there's an intervention where they've got to be appraised of the potential harms and hazards of the intervention, etc. It's very light touch. Practices who aren't seeing patients with COVID. Yeah, this is a really interesting question. And I think it really does come down to your locality. There's no one size fits all with this. In some areas, there are practices who are seeing quite a few COVID patients or are going to. In some areas, they're more or less still being passed off to a hot clinic. If you have a hot service that you would pass a patient onto without really doing much assessment at all, like it's COVID, you need to talk to the service, then perhaps we should be recruiting that hot clinic and any neighbouring practices around that who are working with them. So perhaps you would get the team in Oxford in touch with the hot clinic, and we could perhaps see about recruiting them. The way this is running, as I say, in Northwest London, it's across the whole patch. Some bits of Northwest London have hot clinics, others don't. It depends on the CCG. But a good thing, perhaps nationally, would be to have an area with high prevalence or rather high incidence of COVID, a local hot clinic that's using EMIS, writing into the records, plus some local practices are supporting that, all working together in a cluster. That might be one way of doing it. How quickly we're rolling this out? As soon as possible, especially in the areas that have high incidence currently. The study is open, the templates are available. You can load them up. Merlin, perhaps you can touch base on making sure you have the loaded templates, and you can start tomorrow on Monday. Merlin, do you want to cover off?
Yes, I think one of the questions that came through prior to the webinar was problems accessing the template via the portal. So I'm just going to share a different screen so I can show you that. So the portal is accessed via ardens.live/portal, and when you first go to the portal, you will find that you need to sign up, and the reason for that is that we need to be able to tag who has actually downloaded the template in case there's any updates or anything. We know who we can contact. So although it's freely accessible to everyone, we would ask people access it via this route rather than copying it and sharing it via email or something. But once you've logged it, once you've signed up, the sign up page looks like this. Just ask for your name, email, then a password for you to access the portal, and which practice. Now the practice is important because that's what's going to link you to your practices. When you log in for the first time, you will see any practices that you're associated with on the left hand side here, and over to the right you'll see the select button. So you select the practice that you want, you click on that, and it will show you the resources that are available. Now the resources available to different practices will be different because some of them are subscribing practices to our full product, but any practice should be able to access the COVID-19 template. Sorry, it's being a bit slow to load at the moment. All right, here we are. So on the right here, the version on this page is 15.7, but it's being updated today to 15.8, which is the version I just showed you. So you simply click on that and you'll get a download link for the template. There are instructions on the website, which I believe Liber, Alex, or some combination of putting together some FAQs and some instructions on this process, and also on how to import the template into your EMIS system. So that's pretty much an overview. You just have to sign up the first time. There's the download link. It's an XML file. So the only other thing you may have to get over is that some NHS IT local organisations block the download of XML files. So you may have to get some local IT permission, but it hasn't been a problem as far as we're aware anywhere to date. Are there any other questions that came through relating to the process?
We did have a question come through to the FAQs before the webinar, that somebody wanted to know how the template is triggered and which codes will trigger the template, or if it has to be manually triggered.
Yeah, an excellent question. So there is a template which can pop up in EMIS. That is an EMIS template. It is not the Ardens template. The only exception to that would be if somebody in your practice has built a local protocol to launch our template, but the default of this template is it's manually launched. Now you can, of course, if you wish, add it to your F12 menu from be able to launch from there. But we certainly as clinicians felt that it's very annoying having things popping up all the time. So the answer is there are no codes which will trigger it. You launch it from the template runner when you wish to use it.
Okay, that's a very important point actually, because I'm an EMIS user in practice, and you're right, there is a thing that says, is this a COVID patient? Do you want to use the template? So we need to make sure that people don't use that, but use the Ardens template.
Yeah.
Merlin, there's a question for you popped up on there. I'll come back to the earlier ones in a second, but might as well. In fact, there's 3 related to that.
Sorry, do you want to read them out? I haven't got access to that.
Sorry. The last question says, as Merlin is in Oxford, have you spoken to PML about the hot clinics around Oxfordshire and how their staff will know to use the template for OSC practice patients at the 3 OCCG CALM clinics?
So the answer is I can't speak for specific practices, but the OCCG has certainly endorsed our template from the very earliest stage of the pandemic. When we had the first wave, this template was in existence within a few weeks. It's of course been updated and improved ever since then. So the template back then won't be the same as it is now. But certainly all practices have had free access to this, and it has been publicised via OCCG communications. So the answer is I can't tell you exactly who's downloaded it and is using it, but the offer has been there for several months.
Issue of linking up CALM clinic data to RSC.
I feel like I can lead in on this actually. If you're working from a CALM clinic or a hot hub or anything like that, we can still extract data from you. The hot hubs will have to be in touch with the hot hubs to get this set up. So if you're using a hot hub or a CALM clinic, can you please get in touch with myself or the PLO team at the RSC, as we'll only be able to take patients from the hot hub that are permanently registered in an RSC practice. So this won't be a problem for you. You can just carry on as usual. However, this might be a really good opportunity for us to recruit further practices into the study using the CALM clinic. So if you could just send any information about that to myself or Liba, we'd really appreciate that.
Okay. Someone's asked if the Ardens download site link could be sent out as well, practices, because they can't access it at the moment or can't immediately see it.
So yes, I think that's coming out in the FAQ and study information pack, isn't it? And there's also instructional web pages to go through how to do the various things on our website as well, which we can give links for.
And James has asked a very sensible question. Is there a specifically approved wording for sending out the SMS to patients to link to the study info? There isn't, because it's left to verbal consent with the GP. So the GP would say whatever they want to say. I'm going to send you a link that's got some more information about the study, and then you just send them the link. Okay, I think we've covered everything that's there. I think I've covered everything from my point of view. There's lots of material on the RECAP study website, including all the information for patients, including the consent sheet and information sheet, a page for information for clinicians, and all the details of that. So that's probably all I needed to cover. Other than strong encouragement, please do think about taking part in this. I think of all the research that's ever been put forward, getting a handle on risk when seeing patients with acute COVID in primary care is really, really, really important. It's a huge patient safety issue. It's a huge topical issue, and it's worthwhile putting the boat out for a couple of months just to gather the data so we can reliably say to patients, your risk is low, you're okay at home, or because of these features, I need to get you seen. And just think, as GPs, having the ability to do that reliably rather than grasping around in the dark as we currently are, really important. So Liba and Oxford team, anything else you want to add?
No, we've just got one more question that's come through the chat, the RSC chat just now, about how practices are going to be compensated for the study with regards to payments.
Okay, so my understanding from a discussion that Trish Greenhalgh and Simon de Lucenant had a couple of weeks ago is that the RSC practices are going to get £150 for the site, but they need to be an active site, which is being defined as 10 patients using the template. Will then trigger the active site reimbursement, which covers issues around consent and the extra time. There is also, for all practices, payment from service support costs from the CRN, which is currently being looked at to work out what it is. My estimate is it's probably going to be about the same amount again. And it'll be a combination of a setup payment of that amount, plus a payment probably of the order of £15 to £20 per patient for the additional data collection. So it's a fairly well-resourced study actually across the CRM and also the additional research costs, given the additional work involved. Yes, is the answer to the last question. Amelia Lewis. Yeah.
Great, thank you. Just a note for all the RSC practices that are on the call, I will be your key point of contact throughout the study. So if there's anything that hasn't been answered or that you need clearing up, please just send me an email either directly to myself, my email's on the invite, or to the practice inquiries email, and we'll be able to guide you further.
And thanks for your time, everyone. Busy time at lunchtime, I know, but thank you for taking the time. Okay, bye.
Thank you, everyone.